Hello, everyone, and welcome to this next installment of Child Life in Action COVID-19. In this series, we're interviewing child life specialists to discuss the impact coronavirus has had on their work and some of the unique and innovative ways they are adjusting to these new demands that this situation has created for them, both personally and professionally. I'm Meagan Roloff. I am the Director of Member Engagement and Partnerships at ACLP, and today I am thrilled to be joined by the wonderful Hilary Woodward. Hilary, can you introduce yourself to everyone? Tell us a little bit about you, where you work, and what your role is.
Thank you, Megan, so much for having me. Like Megan said, my name is Hilary Woodward, and I'm a certified child life specialist living and working in New York City. My primary role is clinical, working in the Pediatric Emergency Department at York-Presbyterian Stanley Children's Hospital, which is a level 1 pediatric trauma center that's part of Columbia University Medical Center. I also am an adjunct faculty member at Bankstreet College of Education in the Child Life Graduate Program. And I'm the director of Child Life for Basecamp, which is a simulation-based pediatric emergency medicine training program for physician fellows, for nurses, and for child life specialists.
So we are definitely going to come back to Basecamp because that is an incredible program that Hilary invited me to observe this past year, and we definitely want to touch more on that. But to start, just as an emergency room child life specialist in New York City, can you tell us a little bit about what you're seeing on a day-to-day basis? I think for those of us in the US, we're seeing a lot of news and media coverage out of New York City, but really more on the adult side and very little, if any, on the pediatric side. So we'd love to hear just kind of what your world is looking like these days.
Sure. So there is definitely some good news on the pediatric side in that COVID-19 doesn't seem to be impacting the majority of pediatric patients to the degree of severity that it's impacting adult patients. So in our pediatric emergency department, our volume of patients that we're seeing is actually far lower than it typically is in March and April and any other year in the 8 years that I've worked there. So that's definitely a big difference. But I say that with the caveat that I also don't want to diminish the challenge for the families of pediatric patients who do become quite ill and require hospitalization due to COVID-19. So we are seeing and taking care of those patients as well as other patients within our pediatric population. But at the same time, really, it's our colleagues in the adult world and those of my colleagues in pediatrics who have stepped in to assist them, who are really bearing the brunt of what everybody's seeing in the news in terms of the high degree of loss and acuity that's happening with the adult patients who are suffering from COVID-19. So every day for us in pediatrics is sort of this interesting balance of making sure that we're staying on high alert, because certainly COVID-19 impacts our pediatric patients, and we need to always make sure that we're ready and providing the best care that we can for them during this time, but at the same time using some of our time and energy to do our best to support the needs on the adult side.
Sure. So has your approach to supporting children and families changed at all in light of all of this? Do you have new restrictions?
Yes, there's been a lot of changes. I think the way I've looked at this is I still serve all of the same patients and families that I served previously. I just serve them in different ways in order to maintain as much safety as we can. Everything is sort of a constant risk-benefit analysis, and how can we do the most benefit for our patients with the least amount of risk. We've been really fortunate in that our emergency medicine leadership has put some different options into place, not just for child life, but for all of the disciplines who interact with our patients. We have a lot of different telehealth options, but honestly, my favorite option that's been really helpful to me in my practice is that as this all got started, they gave us wall-mounted phones in each of our pediatric exam rooms in our emergency department. And there's a sign inside the room next to the phone to help the patients and families operate it if need be, in both English and in Spanish. That was created by a little small team of our pediatric residents and medical students, which was great. And they also placed a label outside the room with the phone number for inside the room. So what we've done as an emergency team is we've transitioned a lot of our verbal interactions to take place by phone. So when a family comes into the emergency department, their history is taken by a physician via phone. Their introduction to child life services happens via phone. And we've been able to do a wide range of things. We've now done IV support with me standing outside the room on speakerphone.
Wow.
We've done laceration repair support with sort of like a team huddle before like the very most essential people go into the room to provide support. So sort of interdisciplinary team coaching one another, which has been cool. And also just conversations with families, sort of getting a feel for where they are, what their concerns are, and helping orient them to this unusual process that we're all going through.
I love that that's a comparatively, low tech. It's not new software. It's not new, skills you need to learn necessarily. A low tech solution to this problem. There's been a lot of talk within the child life community about more virtual interactions. And then, of course, all the questions, at least for those of us in the US, that come along with HIPAA with all of that. So, it's nice to see kind of a low tech way to also meet that need.
Yeah, it's interesting. I mean, we sort of set up some different things that are a bit more high tech and which on occasion can be really useful. But for most of us just down in the ED, it's been good old fashioned telephone.
Yeah. Now, your emergency department is known for being leaders in using multidisciplinary simulation, and you yourself, with your work with Basecamp, have been a huge advocate for child life being included in those multidisciplinary simulations. Given all of that experience you have with simulation, do you think that's helped prepare you and your emergency department colleagues for what we're seeing today?
Absolutely. And I'm thankful every day that it's a modality I was introduced to. In our pediatric emergency department, we typically do weekly interprofessional simulations with the goal of preparing us as a team for those types of events that are low in frequency. So they don't happen very often. We've simulated some events that none of us have ever encountered in our actual careers. But with the idea being that because those types of events also can be very high stakes, we want to be prepared for them at any time. So having that practice once a week for the past 8+ years, and also being a part of designing that curricula, I think has really helped me to be more flexible in my own practice and to have to think outside the box and how I might adapt to different situations. So although we haven't done much in the way of simulating the exact scenario that we find ourselves in right now, because I don't think that, really many of us saw this coming, that just general flexibility has really helped me to adapt my mindset and my practice. And then specific to Basecamp, that I think has been hugely game-changing for me in that Basecamp actually, it's a weekend-long program. So we do 2 days of immersive education. And about a little more than half of the day is spent focused on disaster medicine. And a disaster medicine mindset really asks everybody to think about when you're in the situation where the healthcare system is stretched to the point that you can't provide for every patient what you would on a typical day. How can you make the resources that you do have stretch as far as possible so that you can do the best that you can? And that is exactly what's ultimately been asked of us in this current pandemic. So having that sort of mindset and that framework that I could switch into and think of this, okay, we're in a disaster mindset now. What do I have available to me and how can I make it stretch? I think helped me make that cognitive leap in my practice pretty early once this happened. And that's really helped a lot, I think, hopefully for my professional capability, but also for, sort of how I've handled the situation for myself internally and emotionally. At Basecamp, we've taken the mindset that, we really feel like all nurses, doctors, child life specialists, psychosocial professionals really need and deserve training in disaster medicine. I think it's something that I hope will just continue to grow. And I think the current situation that we found ourselves in sort of validates that maybe we were on the right track with that mindset.
Absolutely. Absolutely. And even though you didn't ever simulate this exact scenario, though, you're finding those transferable skills, which is fantastic. New York City, you guys are kind of the hub of all the activity around coronavirus right now. And a lot of parts of the country and the world are still kind of in waiting preparation mode, waiting for their area's surge to happen. Do you have any advice for child life specialists that are in areas that are still kind of waiting for COVID cases to pick up?
Yeah, I can think of some things sort of practically that were either helpful to us or that I wish we had been able to do if we had a little bit more time before this hit. One thing that we did early on was to practice some of these telephone and virtual interactions with patients and families as we got the new technology up. And fortunately, as we started to use them, it was before we necessarily had to use them every single
Mhm.
time. And so being able to sort of do it at a slower pace and also really pay attention to how the patients and families were responding. And in some cases, if it was a patient or family that we knew previously, being able to ask them how the experience of interacting with us through this different means compared to what they were used to and how we could improve really was helpful. So I would say definitely to anybody out there who maybe doesn't have to do more telephone or virtual interaction, if you have opportunities to practice it, especially with the patient or family that you know, it might help you so that it feels like less of a leap once you have to do it. Everyone's a little bit more used to it. Also for us, one of the things that I had to adjust to is now that we're in a situation here in New York where we assume that every patient does have COVID-19 until proven otherwise, there are some different considerations that we have for everybody's safety. And those considerations really come to play if we're in a resuscitation type scenario, because resuscitation of a patient with COVID-19 is a very high risk procedure for particularly the providers involved. So there are a lot more considerations in terms of who can and should be in the room, how those providers communicate with team members who are outside the room. And certainly there's a role for child life and a really important role for family support, but there are some new considerations that most of us as professionals have never had to deal with before. So for any of the child life specialists who are involved in resuscitation care, either in emergency settings or elsewhere, I think if there are opportunities to bring up that conversation with your team and ask what the modifications might be, if there are opportunities to practice or even just do some talk throughs so that you have that understanding of how to keep yourself safe, families safe, and support the safety of your team, I think that could be really helpful. And that's something that we're using our simulation brains now, even as we're in it, to try to figure out ways to sort of safely practice those skills as a team and just get better and better at it, even though we can't all be together as a large group in person right now. I guess the last thing would be to maybe talk with teams, both within your child life teams, your interprofessional teams, and maybe your infection prevention and control teams about if there are any specific circumstances in which the types of practices we're doing, like the virtual practices, should be suspended for an in-person model. So an example that we thought of early on is the goal always for safety is to try to minimize the number of staff who are interacting in person with a patient who does have or may have COVID-19. But we also know that sometimes there are scenarios where patients really cope a lot better and are able to tolerate a procedure better with a child life specialist versus maybe 3 people holding them down. So what is the process if you find yourself encountering that situation where it seems like the safer scenario, both for staff and patient, might be for child life to be involved? What's the best way to go about that? Like, is there something that's open for a team discussion? Is that something that should be discussed elsewhere, or how you can best fit in your assessment to create the safest situation possible for everybody?
All great advice, and I hope helpful for those in the child life community that are still kind of in preparation mode. To close out on a more personal note, how are you managing with all the changes that COVID-19 has brought? How are you sustaining and taking care of yourself?
I think it's a tough question to answer because there's the situation that we're in now is just so unprecedented, and the degree of loss and suffering that we're seeing and that I think the whole world is seeing in some way, shape, or form is just really challenging for everybody. I will also say, though, that at least here in New York, we're seeing some unprecedented acts of kindness and bravery. Silver linings abound here. Every day at 7:00, the entire city bursts into applause, for everybody who's out there on the front line, whether that's in healthcare or, out there working in the grocery stores and the pharmacies and the nursing homes. My applause is also always for, the people who are also staying home and who are doing, their best and making sacrifices to help others stay safe. I think that's something that will stay with me long past this is over. There are people in our community who are keeping us fed in the hospital every day. We're getting cards, we're getting artwork. Just the gestures are so incredible. And it doesn't surprise me about New Yorkers. New Yorkers are incredibly tough and kind and brave, but to see it play out is really amazing. And I'll also say I knew before this that I was part of an incredible team. But our whole emergency interprofessional team, like just the degree of grit and grace and professionalism and brilliance, like it's just beyond. And I think about that a lot and hope, and I do think that ultimately those are the pieces that will stay with me when looking back on this in the future. So there's always good things to focus on.
Definitely the good things. Well, on that note, I don't want to take up any more of your time. I so appreciate you making the time to do this interview with me. I hope this will be helpful and beneficial to child life programs across the country, around the world, as we all continue to really lean into our creativity and flexibility to adapt to the constant changes. And just on behalf of everyone at ACLP, thank you for doing what you're doing to help children and families, and also still being willing to give back to the child life community. It means the world to us.
Thank you. And I also would love to say a big thank you to the child life community. I can't even tell you, I was actually trying to count today the number of states and provinces I've heard from child life specialists in, most of whom are connections, through the ACLP, through committees, through conferences, through base camp, and also the ACLP staff. Like, the support has just been incredible, and I think is such a testament to our community. And I'll speak for myself, and I think many of us in New York, that we would love to return the favor. So we would love to hear, at least I know I would, and I think many others would love to hear from anybody who we can either help or encourage or support. So please don't hesitate to reach out.
Absolutely. Well, thank you again. And everyone else, we'll see you for the next Child Life in Action.